on the wards. So I've done a bit of everything really. So as a specialist research nurse for leukemia for 7 years, which was also a regional service, a bit like the TTP patients. I was also a research nurse, and I looked after the non-malignant side of haematology for 2 years. And then I looked after my first TTP patient in 2017. And I started in post March of 2019. So I was really lucky to look after a TTP patient in 2017. I was involved with the Hercules study, which was to do with capsuzumab. So I was one of the first nurses in Liverpool to give it. And when I first met that patient, I never really looked back. And I loved the patient group from that instant onwards. I've looked after lots of different haematology patients, but TTP patients, I can't explain, but it's an emotional thing for me, which is a bit, but I felt I could make such a difference to them. So that's why I wanted to be a TTP specialist nurse. So the value of a specialist nurse in TTP. So a specialist nurse is a prerequisite to being able to provide a high standard of specialist care to this rare patient group. So what does that mean? Basically, it means that you need a specialist nurse to provide some support basically, so you can get the best care possible. So this is a bit that Joe talked about before. So TTP specialist centres. So there is a specialist service specification with funding from NHS England. So this is just for England, and there's going to be 8 to 9 centres spread all over England. And London and Liverpool are definitely going to be some of these centres. But at the moment, the other centres out there have done something called tender, which is basically where they show what they can do, can they perform that service. But as part of that specification, the most important bit, which I'm probably most excited about, is those specialist centres have got to have a clinical nurse specialist like me or the nurses in London for patient support. So what do I do? So as part of my role, I do a lot of education, guidance and support to patient and family. I do a lot of education around TTP for patients and carers. I think the main time I do this is at diagnosis. I do a lot of this. I go a lot to the patients and go and see them, sometimes multiple times in a day, to go and talk to them, and then again to speak to their family and carers, but also at other times, so relapse, lots of different times I go back and do more education. And obviously ongoing emotional support, we know how important that is for TTP patients, but also we know that maybe patients need a bit more than that as well. And although I can definitely give some of that, I've got good communication skills, I think also it's about knowing about things like psychological support. So, and as part of the specialist service spec that's coming, there should be some psychology support for patients as well. So that's really important, and nurses will be able to signpost patients to that, which will be really important. It's also, I help the patients learn how to manage their condition, sort of explain it more, see if there's a different way we can think around problems. I think also, especially where we are in Liverpool, we're very patient-centred. We try and think about your quality of life, how we can improve things, how we can make things easier just by simple things, like very simple things like making sure you can come at a certain time so it's easier for you. I help with a lot of issues around employers. A lot of employers don't really understand about TTP, so I write lots of letters and things to employers to explain. It sort of makes things clearer. Also in the last especially in the last 4 months, there's been a lot of issues around COVID-19, and I've spent a lot of time, especially when lots of patients weren't coming, a lot of patients were ringing with queries and text messages and emails, and what do they need to do, and what were their problems, and some people had problems with their employers. So I spent a lot of time helping patients sort those things out, and I think that's actually going to be an ongoing thing. I think for TTP patients that's a very scary thing, and I've had lots of concerns about that, and I completely understand that. It's been a stressful time. And also, I suppose, as I was a research nurse, I supported patients to be part of research. I'm very proactive in this, which I think actually all of the TTP community is. But we know that it makes such a can make such a difference for the patient, but it can also make a difference for other patients as well. And I think it's really important to be part of that. So patient information, do a lot of that. So we have at our centre, we have specialist patient information leaflets, and I also give out specialist centre contacts, and also with sort of out of hours numbers on as well. I give out alert cards, and also discharge talks. We talk about long-term follow-up, and also I write letters to the GP. And also I write holiday letters as well. This is an example of a holiday letter. I know unfortunately not many people are going on holiday at the moment, but in the days when we could go on holiday, I used to write lots of holiday letters, and these can be really important if you're going somewhere. And at least if something happens to you, at least you've got a letter that you can give to whoever you see. And I know that the TTP network also has letters which have been translated as well, which is really important. So they're very important and can really make a difference. And also I help with insurance as well. I think I know from back in the day when I looked after cancer patients, insurance was always tricky, but for TTP patients, getting holiday insurance is also a problem. But I have some good kind of lists of insurance companies that aren't too dear, so that's always very helpful. Patient advocate, so I think that's probably one of the most important things I do. So I'm the main point of contact for patients during their patient journey. I try to deal with problems and queries quickly. If someone texts me in the morning, I try and sort things out as quickly as I can. And also things like if patients want to come and have their bloods checked, if they're worried, if they're relapsing, if they're worried about something, I try and get them in and get things sorted, or get them to their GP if necessary. Just try and direct them in the right direction quickly. Really, I want patients to come to hospital less if we can manage it, not more. And I don't want patients to stay as inpatients. We know we're trying to get patients out if we can. We don't want you to stay in hospital. We want you to be at home. I do a lot of communication between other healthcare professionals. So this is GPs, this is the ward-based nurses, this is ITU, this is other haematology consultants that may be in your area. So I do a lot of communication with all different healthcare professionals all over, especially the Northwest. So I deal with like all the way from Cumbria to, you know, Wales, so all over the place. I deal with lots of communication just to make things easier, really, so everything's joined up. And probably the most important thing for me is patient safety. I want all my patients to be safe, and that's a really big thing. And I think that's probably one of the big reasons why having a CNS is so important for TTP patients, for these specialist centres. It does really improve the patient safety, and that's what everybody wants. So outpatient clinics, so we just have one clinic a week, but really we want patients to spend less time in clinic. We don't want you hanging around for hours. So it's trying to, as specialist nurses, often we can see sort of awareness and patient problems and issues beforehand. So obviously infection is a big problem with relapse. So it's things like if people have got a urinary tract infection, we're trying to get things sorted quickly, and also specialist nurses can see patients instead of medical staff. So I often see patients myself, and trying to make things a bit smoother if we can, and also sort out problems as we go along. I definitely, I would say me and Dr. Dutt spend a lot of time when the normal world of clinic, trying to sort things out so everything's sorted on the day and patients have gone away with letters or whatever they need. Patient support group, so this is really important. So in Liverpool, our patient support group started in 2017, and we feel it's really important to support our patients, families, for a shared experience. We have done things like, we give a lot of updates about what's been happening in the world of TTP. We've done a lot of tours of our specialist coag lab, which I know has gone down really well, to have a look and see what Adams testing is like, what actually happens, what happens to the samples when they go to the lab, meet some of the lab staff. Our lab staff are very interested in TTP patients, are always asking how they're getting on. And obviously the TTP network is a big part of that. We're very lucky to kind of be involved, been involved for a long time doing things with them, and we definitely want to continue that. And I think all the patients in the TTP all across the UK should be trying to get involved with the TTP network and getting involved with what's happening. And this is just a bit, this is just a sort of a show you of what our invite looks. So we actually invite all our patients personally. That's just how we've always done it. And it's just kind of an opportunity to meet other patients and share experiences. And most importantly for our support group, it's a time to have coffee and tea and eat a lot of cake, which is what we normally do. And usually we spend a lot of time we have two sort of a session in the beginning and at the end, but we spend a lot of time in the middle just all talking, eating cake. But that's probably one of the most important bit. It just gives an opportunity to meet other patients. But I suppose it's just in the world of COVID, it's become much more difficult. So things like these Zoom meetings are so important, that people are attending and seeing what's going on. And then educational sessions. So I do a lot of teaching of other healthcare staff about TTP, like I said, back to teaching on the wards, ITU nurses, other doctors as well. So I do a lot of teaching, so our plasma exchange is done by NHSBT in Liverpool. So I do some teaching with their nurses as well, also teaching of new staff that come to our department. I've done some teaching recently just to kind of update those staff as well. And also very important that nurses keep up to date in general. So I've been attending national meetings around TTP. I'm trying to keep up to date with research, just so I know what's going on. So I'm, as up to date as I can be and know what's happening in the world. And I think the most important thing, I think I want everybody to take home is, I think even if you don't have a specialist nurses, don't be afraid to ring your team if you're worried or have concerns. I think I'm so glad when patients ring me and just say, oh, this has happened, or I'm not sure, or I've got this funny rash, or, that's that's what we're here for. That's what I'm there for. That's what I'm sitting at my desk for. I'm waiting for phone calls. I'm waiting for text messages. I'm waiting for things. So please don't be afraid to ring your team if you have worries or concerns. And then this is just a picture of my dog and my recent holiday to Devon. I don't even know how I got on holiday to Devon anyway, but he's enjoying the lovely view, which is nice. Always have to put a picture of my dog on presentations. So sorry it wasn't very long, but I just want to say thank you. And then if you've got any questions, please send them to Jo and I will try and answer them.
Thank you so much, Jo. That was really interesting. We have got some questions, so I hope you're ready. And yeah, there's more coming in all the time. So I'm going to do my very best to read them and not forget any and not lose track. But I've got Anne as my right hand man, so she'll help me. Well, I've just unplugged my computer. I better plug that back in just in case it means the session dies. Okay, so let's start. Right. Question 1. How low can your ADAMTS 13 level reach for you to still be allowed to have vaccines like flu and possibly COVID-19 if there was one? And would you maintain those antibodies that you obtained from having the vaccines if you then, soon after the vaccine, had rituximab?
So I think so actually I've done some research. It's always good to find out. So I think that we have suspected in the past that vaccines may trigger a relapse, but we have no good evidence for this. But it's still a little bit of a possibility. So I think we would avoid patients to have vaccines with an ADAMTS less than 10 or in the first year post-acute treatment for TTP. And then we would not advise patients to have vaccines for 6 months post having rituximab.
Thank you. So the next question, given that infections and surgery are possible triggers for TTP, would it be safe to have a tooth extraction whilst your ADAMTS 13 level was around 30? Is there an ADAMTS 13 level at which is strongly advised not to have surgery?
I think the most important thing for surgery is what is your blood count like? I think if you're needing a tooth removed anyway, if you've got infection around that tooth, you still could trigger relapse, so you might be better having it out anyway. So I think as long as your blood count is normal, I think an Adams of 30 would be fine. I think it just depends on your individual circumstance and what treatment you've had recently. So you'd always be best to go back to your team to ask them for advice about that.
Brilliant, thanks, Jo. And I need to make a huge apology. I've recorded this session and I haven't warned you that I've recorded this session. So what I have recorded is literally Jo's slides and Jo's voice. But if you have any concerns, if you contact me either on the messenger or on the email info@ttpnetwork.org.uk, and I do apologise, I should have said that at the very beginning of the session. We've got more questions, Jo.
Okay.
Are the TTP treatment centres available for patients from abroad?
Now that's a good question. Now, I think it would depend where you were coming from abroad. I think that's a bit of a tricky one. I think also with what's happening with Brexit, I think things will change as well. I think if you were an EU citizen, things might have changed. I think you'd have to contact where you would want to go and ask them before you presented there. I think that would be your best bet. If you know you've already got TTP, I think you would be best to ask them and find out what their local policy is, because definitely the world is changing with Brexit looming. So yeah, I think I'd find out.
I'd concur with that, Jo.
Yeah.
I think, and we have the specialist centres aren't even in place yet.
No.
Other than really Liverpool and UCL will be the first two, but so we don't really know what it's going to look like for all those kind of complications. We've got a fairly good roadmap of what it should look like for patients in England, but beyond that, I'm sure we're going to be learning as we go along. So good question, and it's something that I will try and find out for myself. Next question, roughly how many patients per specialist nurse?
Oh, well, so I've got around 70, but every centre might be slightly different. It depends on their catchment area. I know London is a lot more, obviously, and they've got more specialist nurses. So I think it'll depend on the catchment area they're actually looking after. Hard to know. It'll be slightly different for everybody.
Different feast.
Yeah.
Next question. What changes have you seen during COVID, i.e. any differences in relapse symptoms and treatments, if any?
Oh, sorry, you'll have to repeat that, Jo. You
disappeared. Oh, sorry, did I disappear? Sorry,
it might be me.
No, it might be my internet access. What changes have you seen during COVID, i.e. have you seen any differences in relapse symptoms and treatments, if anything at all?
I don't think we've seen any differences. I think it's really hard. We may have seen things, but we don't know yet, and there's no research out there. It'll be interesting to see what research comes from this, what people have found, but it's unknown still at the moment.
Brilliant. We had a question, where are the 8 to 9 centres in the UK, please? I know that neither of us can answer that.
No, no one knows yet. No one knows.
No. TTP Network, myself and Seda represent the network, and we sit on the commissioning panel. So we will be party to seeing who will be applying, but we won't be able to share any information with you about those meetings. We've signed confidentiality agreements until such time as the news is able to be published, but rest assured, as soon as we can let you know, we will. Next question, if you had Ritux over 7 months ago, would you expect your CD190/20 to still be at 0?
Possibly, yes. Yeah, and that doesn't mean that, as much as I know, that doesn't mean that's a bad thing. So no, that's okay.
Okay. What advice do you give employers when people are returning to work after the first episode of TTP?
I think it's just to kind of be aware, and that obviously going to their appointments are very important, and also I think it's also telling the employers that if the patients need to come and have their bloods checked, or if they need treatment, that's fine. And I often provide letters for employers that say they're going to need rituximab, or they've had to come for this appointment. So I think it's just to be aware they might need a bit more sort of being able to be let out for appointments as and when all of a sudden. I know that's a bit difficult, but it is that kind of condition where you can't really wait sometimes, and you just need to do things. And I think employers need to be aware of that.
Brilliant, thank you. And now a question similarly on the specialist centres. Do you have any idea what's happening about them for Wales or in Scotland? And the answer is really the same. It doesn't come under the same process as for the England centres. They're dealt with by NHS England. However, I'm told that the other devolved states will tend to watch fairly closely what's happening in NHS England. So the chances are they might be looking at it. But I would say there's nothing stopping you asking your health board what they're doing and whether they've got plans, and push the agenda. And if you want some help with that, get in contact, info@ttpnetwork.org.uk. Okay. Do people usually experience the same symptoms each time they have a relapse of TTP?
No, I'm not sure. Some maybe do, but I'm not sure it's always like that. Some people don't know at all. It depends what kind of relapse they're having. If they're having an acute relapse where their platelet count drops and they need plasma exchange, it can be different than if they're just having a relapse where their ADAMTS drops and they need rituximab as an outpatient, which is slightly different. It's kind of a preemptive approach. So I don't think there is a kind of hard and fast. I wish there was. I wish we knew exactly, but it's a bit sort of, it just depends.
Yeah. Okay. Jo, there's a thank you here. Thank you for your presentation. What does your average day look like? Do you work 9 to 5? Do you attend the ward round? Do you have cross cover with other team members?
Yeah. So I work 8:30 till 4:30. Generally my day looks like looking at emails, seeing what's happened overnight, and then usually if we've got any patients on the ward, seeing what's happening to them, have they had their bloods done, what's going on. And then usually, yes, we could go on the ward round, which is in the afternoon in Liverpool, but sometimes it can be in the morning as well. It's just whenever people are ready to go, I have to go to. And I do have cross cover, so I have someone working with me at the moment, which is really nice. So yeah, there is people to cover. Actually, there's quite a few people now. There used to be less, but there's more now, so we've got a few more staff. So there's a few people around that are available to cover me, which is quite nice.
Brilliant. Okay. Do you know if any TTP patient has had COVID-19 and has it triggered a relapse?
See, I think this is going back to the previous kind of answer, and I think we don't really know yet. We may have seen things, but it's hard to say if that's something yet. As I said before, there's no research out there. It'll be interesting to see what research comes. Yeah, it's a bit of still a bit of an unknown. There's been no relapses in Liverpool, but I don't know about the rest of the country. We just have to wait and see what research comes out and if any sort of case studies, as they called, sort of get published. So it's just a waiting game a bit.
Okay, brilliant. And now we've got two questions that have come in next to each other from different people that are very, very similar. So they're saying, what's the treatment area size? So I'll ask you that question first, Jo. What geographic area do you cover?
A ginormous area. So we cover Cumbria, probably not maybe the north of Cumbria, which might go to Newcastle, kind of South Cumbria down. So that covers, then we cover Preston. We also cover Manchester and the surrounding areas. So we cover Bolton, Rochdale, the other side of Manchester. And then we cover a bit of Derbyshire as well. We would cover a little bit of North Wales, maybe. And then obviously all of Merseyside and the Wirral as well. So it's a really big area. It's a big area we cover.
Big area, and luckily a small patient or a rare, very rare disease,
Yes.
so very rare disorder. So your patient numbers may
Yes.
be manageable.
Yes, exactly.
The other question, and so this is the question where two people have really asked the same, is are all patients expected to attend the main hospital regularly? And this, I think, is referring to the specialist centres.
I don't. So we do have something called shared care, which we have with other trusts as well. So no, not always. So we do like to see our patients once a year, but some of the other stable ones can go to local sort of district general, or their sort of more acute trust that has a haematologist, and they can send their Adams samples to us. So no, they don't always have to come to us, but we do like to see them now again, just to kind of touch base, make sure they're okay, and just kind of keep an eye on things. And then we use the other hospitals to kind of do a bit of care as well.
Brilliant, thank you. And that's really important that you're speaking from the perspective of Liverpool, because we of course don't know the other, it hasn't actually gone out to tender yet for the other centres, so we don't even know who's even applying to be a specialist centre. And I think there probably will be a slight variance across centres depending on what those regional hospitals look like.
Yeah.
Okay, another question. Have there been any patients who in relapse have just received Cablivi, Caplazumab, and avoided plasma exchange?
Not that I know of. Not in Liverpool anyway. I don't know if there's any other anywhere, but not at our centre.
Brilliant, thanks, Jo. Have we got any other? Oh yeah, one more question. So if you've got a question, if you've got a burning question, I'd type it now, because we're on to the last question. How often do you do ADAMTS13 enzyme levels in stable patients? So how often do you test them? I think that's saying.
I think it depends how long you've been diagnosed to start off with. So I think if you're newly diagnosed, we kind of do people like 1 month, sort of 2 months, 3 months, and then see them every 3 months. But if people have been stable for a while, we maybe stretch them to 6 months. It just depends what's happened to them and what's happened at their kind of initial diagnosis and how far out they are. But that can change. I know very well that we look at ADAMTS results and change our minds and decide to bring people back sooner. So it's not always set in stone, unfortunately. We go off what the trend is like in the ADAMTS a bit more.
Yeah, brilliant. So what else have we got? So do your patient cohort ring Liverpool directly out of hours, or do they attend their local emergency department with an alert card if they've got any concerns overnight, say, or a weekend?
So they can do both. They can ring Liverpool for advice, and then actually Liverpool can say, actually go to your local hospital with your alert card, and then at least they've got their alert card. So as soon as they get there, people are like, oh, you've got TTP, oh right, we need to call haematology. And then what usually happens is our registrars and people then follow up with that patient. So we chase them and see what's happening and check that everything's okay. And if I was in the next day, I will be chasing to find out what's happening with that patient to make sure they're all right.
Brilliant. Okay. And so, for example, if someone was diagnosed in 2012 and stopped seeing a haematology team a year after that, would you say they'd still need to be getting monitored?
I think that's a bit tricky. It's hard to say because you don't know their case. 2012 is a long time ago, but it's hard because I don't know what the previous history has been like. I think in Liverpool, even if people have been diagnosed a long time ago, we still try and monitor them just to keep an eye on them. I think it's a safety thing, and there is always this little, risk of very late relapses that does happen. So it's always best to get seen.
From what we've seen in the network, I would say that's a very similar ethos to what UCL have.
Yeah.
And I would say probably Bristol as well. So I would say get back in touch and see if you can get an appointment set up and something regular. Yes. Okay. and somebody had a very similar experience, so no checkups at the hospital years at all since a year after diagnosis. Should they be having regular checkups? So I think we've covered that. I'm going to ask you, Jo, about travel insurance company lists. I've got a
Yes.
list, and I have put stuff on our Facebook page, and I always I've tagged it so under the name insurance, so anybody can look at it. But I think it would be good for us to have a chat and see if we can draw up something to perhaps to put on our website.
I think that'd be a brilliant idea. I know, like I said, from when I worked in the cancer era, and you got ridiculous prices for insurance. I literally mean more than your holiday, just crazy money. But there is some really good places out there that are much more reasonable and kind of really understand what TTP is, which is much better. That'd be a great idea.
And that's the important thing, isn't it? Because it's all very well having a really cheap policy, but they need to understand what the condition is, because when you come to claim, you want to know that they understand and they're not going to refuse to pay or to get you the access to the care that you need. So okay, brilliant. Is it rare to have a normal, oh, my screen's moving, to have a normal ADAMTS 13 but still get TTP?
You wouldn't really have TTP. You'd have to have a diagnosis of TTP, you have to have an abnormal ADAMTS. So they say less than 5. It'd be very strange. I don't know what quite's going on there, but the diagnosis of TTP is to have an ADAMTS less than 5 at diagnosis.
Okay. Oh, here we go. I can never say this word. If being treated with mycophenolate and diagnosis and treatment 3 months ago, should you continue to shield while taking it?
Well, I think the guidance for shielding has obviously changed in the UK now. So if you're in the UK, you could stop shielding from the 1st of August. So we did encourage, in Liverpool, we encouraged our patients on mycophenolate, so MMF, to shield. But obviously from the 1st of August, you can follow the government guidelines.
So, yeah. Brilliant.
But obviously we know that the world is changing again, so it may be that you have to ask your centre if things are changing again.
Yeah, absolutely. When we were just talking about that, weren't we, before we came live, about it? It's just every day it seems to be moving, and what we will look like in a month, who knows?
Who knows? I know. Very strange world.
Oh, very strange. We got another thank you for a great presentation. Love the idea of tea and cake get-togethers, and thank you to the organisers too.
A lot of tea and cake.
And another thumbs up for having a list of insurance companies.
Very important.
What's the most common symptom of TTP that patients have after diagnosis?
After diagnosis, I think tiredness is a big one. So I think all the patients talk about lethargy and tiredness and not feeling the same as they did before and finding things more difficult. And that is completely understandable, and it does take time. And I think, especially if you remember Dr. Dutt's presentation all about the neurology things, is some of it unfortunately just doesn't get any better, and you just got to kind of get used to a new normal, and I think that's really difficult. I think that's where you need to, I think this is where in some ways psychology and things like that really can help, and talking to your specialist nurse or your team about it is really important.
Yeah, brilliant. And if you missed Dr. Dutt's presentation, you can find it on YouTube, and we've got a channel on YouTube. Don't ask me how it works, but I had to put in a load of tag words. So if you look for TTP or TTP network or thrombotic thrombocytopenic purpura or Tina Dutt or Dr. Dutt, you should find the video. It should pop up. So I'm gradually loading all these presentations up onto YouTube so they can be watched at a later date to remind yourself, or if you weren't able to get there for the live session. Okay, what have we got? So can you have symptoms with a falling ADAMTS 13?
Yes, definitely. Some patients do have symptoms, sort of odd thing, like an episode or something not quite, or feel not quite right. They often describe as something just don't feel right, and that's when a lot of patients ring me and say, I just don't feel right and I can't put my finger on it. and you know that Adams has been dropping, and those are the patients I definitely bring in and I want to get their bloods done. I want to check everything's okay. I think be aware of that not feeling quite right. That is definitely, listen to your body a bit.
Yeah, definitely agree with that, and I've heard others say the same. I've experienced the same, so yeah, totally agree with that. So there's just a bit of information. Wales are shielding until the 16th of August.
Okay.
But we're part of the UK. Thank you.
Carry on shielding.
Thanks both. Interesting presentation. Somebody else, thank you very much again for an informative session. Thank you, Jo Bell. Thank you, Jo and Jo. Now Anne's asking me. Oh, Anne, there's a question. So just going back to that about having symptoms with the falling ADAMTS, what level would it need to get to before you start getting some kind of symptoms?
I think this is really difficult because some people, I think it depends on themselves and how, I think it depends what your normal ADAMTS runs at, because everybody's is slightly different. So I think it's a bit of a tricky one, that one.
Yeah.
I think back to looking at the trends, which is what us people in the world of TTP do a lot. So it's looking at the trend, and I think sometimes the people that have a big drop can feel kind of all of a sudden feel not quite right, but it doesn't mean you actually need treatment yet, but you do need to be kept sort of a close eye on and being, coming to have your blood tests.
Yeah, brilliant. More thank yous. Oh, this is a good one. How quickly does the ADAMTS drop?
Oh, it's hard. Yeah, back to it's a bit of a guess. Don't know. It's tricky, and it depends what's been happening to you. So obviously things like infection and things can make it drop quicker. Sometimes people have stressful situations that cannot help. So don't know. That's why we keep an eye on it so closely. And I think if it's getting more around the 20-30 mark, definitely in Liverpool we bring people back quite often to keep an eye on it, just to check things are okay. Because when you're getting to under 20, under 15, you want to be treating with rituximab, so we keep a close eye on people then.
Yeah. Have you seen any connection between the menopause and or HRT and TTP relapses?
Not that I'm aware of. I might have to find out a bit more about that one, because sometimes hormones can play things. So I will find out. I don't know.
Thanks, Jo.
Not a problem.
Very similar. People must be very psychic with each other. So different person, very similar question. Any patients taken topical HRT which has caused TTP?
I don't know. I'd like to find out. I'll get to you about that one.
Sometimes ADAMTS goes up. Have you seen that, and why?
It can happen, yes, and it just especially if sometimes people have had a little infection. Sometimes you can get a little drop and then it goes up. Don't know why. Just it does sometimes. Sometimes it just recovers of its own accord. We don't know. That's why we keep an eye on these patients. We keep an eye on patients so much. Yeah. We just like back to we're looking at the trends. That's why you might have to come in a bit more often, perhaps.
Yeah, brilliant. And what level can platelets get to in pregnancy and not be TTP? Oh yeah, because your platelets will drop in pregnancy.
They do, but I think if you're looking at platelets less than 20 and you have other symptoms, I think that's I think it's a bit of a tricky one. There's a few things that can happen in pregnancy that also look like TTP but aren't. So yeah, I think it's just about those. We're very lucky in Liverpool that we have our women's hospital is not very far, and they're very good at kind of keeping an eye on these patients for us. So if they think it looks like it might be, they send us samples quite quickly. But I think if you're looking kind of under 20 and there's other symptoms going on, I think then you'd be a bit more worried. But yes, dropping platelets in pregnancy we know is normal, but also there is other hematology, heme obs teams which should be keeping an eye on those patients as well. So there's hematologists that look after pregnant ladies.
Brilliant. Thank you ever so much. Thank you, Jo.
No problem.
Really so much for your time this evening, because you've done a day's work already, and then you're coming in to do this. Thank you everybody for logging in. I think that's all the questions. We've got lots of thank yous, but I'm saving the chat, Joe, and I will send that on to you so you can see for yourself the thank yous. Yeah, I just wanted to mention two things. There'll probably be more than two because I do witter on. Joe mentioned holiday letters. I know a few of you are going away, and maybe just for the future, when hopefully 2021 we can actually get away without any worries. On the TTP Network website, we've got a whole list. We've got something like 12 or 14 different languages that we've translated a very basic letter into, and it basically says this person, and then there's a gap for you to write your own name, has a history of TTP, and it's given its full name. Please do not give them platelets because this is contraindicated. I can't say that word. And it also leaves a space for you to insert the name of your consultant and their contact details. And then and the idea is you take a copy in English and a copy in the destination language, and then you can then show that to whoever you're being treated by, and hopefully they will make contact with your consultant. I just wanted to give you a little bit of an update on Caplazizumab and the assessment of it via NICE. So they met for the second time, and thank you to everybody who gave their comments, sent comments via the website, or sent them to me to upload to our organisational response. So they met a couple of weeks ago, and we were due to hear about a week later. And I've had an email to say they're not in a position to share any news at the moment. So it's really frustrating. I've written to my MP actually to say this is dragging on long enough. They've decided to assess it, even though lots of things weren't assessed, and lots of things have had to take a backseat with COVID. They made the decision that they would run with looking at this. So why are they now stalling? What's going on? So I'll just leave that there. I sent an email to my MP. I'm waiting back to hear from her, but that is something that we all have the right to do if we feel something's not going right. There will be more webinars, you'll be pleased to hear. The next one, I'll be sending the date out very soon. It will be about TTP Network. So we'll be explaining to you all the things that we do, all the things that we've done, how we started, what the future might look like. So if you don't know too much about us and you'd be interested to know some more, then do sign up for that. I haven't organised the date yet because I just haven't got that organised, but I will advertise it everywhere. I'll be sending out an evaluation as always, and if you're not already on our mailing list, make sure you leave your email address in the evaluation. I think that's everything to say. Thank you very much, and thank you for all your thank yous. I'll make sure that Joe gets those. The weather's meant to be really good this week, I think, so have a really good week, and if you're working, I hope you manage to get to see some of it. I've got the week off. Yay! Thanks, Joe. It's been really great having you on.
No problem.
And well, look, we're ahead of time. We're within an hour, so you can all go back to your TV. Thanks, and thanks to everybody who's come on board from overseas. It's been great seeing you. Bye-bye.
Thanks.